Welcome to week 8, which is our final week. So that's exciting. Module 8, and we're going to look at health policy and management. And I've labeled this one teamwork. But before we get deep into looking at how the health care and policy management gets in there, I just want to look real briefly in review of the key concepts that we've put this class around. And so at first we looked at epidemiology, right, which is the science of public health. Do observational studies. Certainly try to get at what is the cause of particular problems. So they're problem solvers. We looked at biostatistics, which certainly helps us make more sense out of uncertainty, right? I mean, things don't always make sense, and data, as they say, if you don't measure it, you can't manage it. So that's very important in public health. We looked at the biomedical sciences, right? They do the great things like, help us create vaccines and study vaccines and do research on different things. Also, the genetics that is becoming prominent is part of the biomedical sciences that will help us move forward there. Then we looked at environmental health science. We saw that we've done some great things in the last 50 years in cleaning up our air, our water, and what impact that's had on public health. We're going to continue to do that, continue to move towards cleaner air, a better environment, etc. One of my favorite was we actually spent 2 weeks looking at this, was the social and behavioral sciences. If we are able to pin down what the cause of a particular issue is, and what interventions are necessary. If we can't get people to change their behavior, then it's not a success, right? And we won't be able to help people thrive if we're not able to get them to change behaviors, and that's why it's so important. And also, we looked at like social determinants of, environmental and social determinants of health, right? And so again, we have to take a step back and look at, in what environment a particular person's living in. And I'll give a quick example. If someone's living in a socioeconomic situation where they live in, let's say they live in the inner city and they live in housing projects, they don't have access to the same things that, those that are not in that situation. They may, for example, we can tell them that they need to eat more fruits and vegetables to manage childhood obesity, but if they have to drive, 30 miles to the closest grocery store to get that, it's not likely to happen. So again, environmental factors, our built environment impacts that. And we're going to take a look this week at health policy and management. So again, at the end of the day, we want you guys to understand that these are all working together to help us. What I say is the best thing, which is to help people not just get rid of disease and to manage their health, but to help them thrive, right? Help them be the best that they can be, help them to feel good every day. So let's take a look now at medical care system and public health. So I put in here, teamwork makes the dream work. I mean, public health, we can design all sorts of interventions, but the medical care system participates in that. And I'll tell you what I'm talking about. So preventative care, lots of hospitals, and when I say preventative care, this might mean a vaccine, right? And that's the next one down. Immunizations are vaccines. Without the medical care system, we're not able to administer vaccines, right? So that's a preventative thing. Now, if we're talking about, doctors giving advice on like what is healthy eating and stuff, that is part of the healthcare system. But when we look at the reality of how much time doctors have to spend with each patient, it probably doesn't get promoted as much as it might. But for, it's not that they don't want to, although some doctors, may not think it's important, but that's where we come in and where our messaging out to the populations can help them better learn how to live a most healthy life. Important are prenatal care, right? How you start is absolutely is going to impact things as you progress and get older. Well baby care, testing for risk factors and secondary prevention. So, high blood pressure, diabetes, all these things where you can insert secondary prevention measures to do that. The medical system is important in making that a reality. Treatment of injuries and illnesses, right? We can't prevent all injuries, even though in public health the goal is to minimize injuries, but they're going to happen, and we need the medical system in order to manage that. And then, I put dealing here with the known imperfect execution of public health. Public health will not today and will not tomorrow be able to cure and stop, disease, chronic disease, viruses, injuries and illnesses. So the medical system jumps in and, backs us up when, as that is the reality. So let's take a look at just kind of how in the United States, how the medical care is paid for and how it's structured. So in the U.S., insurance policies and programs include employee-provided healthcare insurance. That's the most common, and the rest of these here, community health centers, Medicare and Medicaid, and children health insurance program. All these are the most prevalent is going to be employer-provided health insurance. With Obamacare, there is the ability to buy that insurance outside of your employer. It still, though, goes through private insurers. 8.5% of the U.S. population is uninsured. And the American Medical Association supports increased access to health care for all citizens. There may be something in there. The American Medical Association certainly, benefits financially when there's more people in the system. So there may be some of that there, but I hope their motivations are pure and that they just really want to provide health care for all. Medicare is part of our Social Security system. It's for people that are over 65. Everyone over 65 is eligible. Plus, younger people that are disabled also can collect on Medicare. The program has two main parts: Part A, which is hospital insurance, and Part B, which is a voluntary monthly premium that covers doctor bills, other things. Part C, and then Part D, which is something that just came about less than 2 decades ago, which is the prescription drug program. Before that change, it was out of pocket for prescription drugs, which created some challenges for many people that are, older than 65. Medicaid, it's a welfare program for the poor. Somebody that is unable to afford insurance, Medicaid is going to cover them. Costs are shared by federal and state governments, and eligibility varies by states, and but that's a program that tries to capture those that do not have the ability to pay, or those that do not have insurance. So there's various licensing and requirements for hospitals, physicians, nurses, dentists. States can discipline misconduct. I mean, you've seen physicians, and I saw physicians in my career that got disciplined, had their license taken away because of misbehavior in what they were doing. Let's talk for a moment, and I believe it's important to talk about these things, ethical and legal issues in medical care. When we're talking about life, abortion is a hot subject, and I told you earlier about my good friend who had his son before he was born. They understood that he was being a Down syndrome baby. They chose not to abort the baby, named him Cash, which showed that he had value. But anyway, abortion is something that is legal, and people are allowed to take the lives of newborns if they are infants, if they so choose. Assisted suicide. Some of you are likely too young, but a gentleman named Dr. Jack Kevorkian helped someone who was suffering from stage 4 cancer, I believe, take their life, and so it was a doctor who had assisted someone to pass on. Right to die. This was a group of people that were told that they could not end their lives, and they moved to different states in order to accomplish that. Uh, Obligation to provide fetal care. A physician and or any medical provider, if someone is in a vegetative state, brain dead, something like that, are not obligated to provide care. So that's something uh, that's important to understand. And for the most part, I would suggest that most families would be in a position, if that's where a person was, that they would suggest that care was not necessary. Treatment of infants with disability. This one is tough because you have something called baby doe rules, where uh, they there's laws that direct physicians that they must provide maximal care to any impaired infant, right? So just because an infant's impaired, they cannot just allow that infant to, because they might say, well, their life is not worth maintaining. They can't just, they have to provide care. Intensive care for low birth weight infants is very expensive and has poor outcomes. Again, I have one of my best friends had a baby that was born. Uh, Gosh, he's 20 years old now. Was 1 pound 7 ounces when he was born. He's perfectly healthy these days. That's not always the outcome, but again, something to grapple with, whether the cost somehow might not be worth the providing them with treatment. And another ethical issue is like organ transplant is a great example. Someone that's in line to get a kidney, you see here the word God committees, deciding who gets a committee. The most famous one that I think of, and some of you may or may not have heard of this person, but Mickey Mantle, and I don't even remember what year it was, but he was on a kidney transplant list for one day and he got a kidney. So there's some ethical issues in whether he was more deserving just because he was more famous or had more means. Uh, and again, I don't know the details behind that, but that's just one example of how we might struggle with ethical issues when it decide who gets what service. So here's our discussion question for this week, and you'll see this uh, on your module. And what I want you to grapple with, and what I want you to look through, and there's no right or wrong answers here, but I want you to support it with some good information. Is, do you believe that all Americans should have the right to medical care when they need it? Right. So, and then, do you believe that the fact, if that medical care had no cost, that there would be any unintended consequences? And then, talk about what have been the positive and negative impacts of socialized medicine in populations. And then just do some Google searches on, the Venezuelan medical system, socialized medicine that started in early 2000s. I can tell you that it was something that I'd done some research on when I got my master's degree about 15 years ago. It was like put out there as the uh, like a very good system, right? Because they were taking care of everybody. And again, I'm not saying what they do is right or wrong, so don't interpret it that way. But their system today, I'll have you research it. So just look at all those questions and then support your responses in your discussion question this week. So let's take a quick look at why the medical system needs reform. Um, the U.S. medical system, it's the most expensive in the United States. We spend more per person or per capita than any other developed country, and that number's growing. There's multiple reasons for that. Right now we're at like 16.9% of the gross domestic product, which is one way that we measure that. We mentioned before that 8.5% of our population is uninsured. Now that's gotten a little bit better with Obamacare, and we can argue, whether Obamacare was good or bad, but it has resulted in more people not being uninsured. And I put here is U.S. getting its money's worth. So there's a couple videos this week that talk about the cost of the healthcare system, but it also talks about whether compared to other countries, whether we are getting our money's worth in the U.S., why our costs are so much higher. So I want you to look at that and kind of grapple with that, as to why it might be that way. And it's complex. I mean, there's not like a one paragraph answer as to why our healthcare is more expensive and if we're really getting our money's worth. Because in all honesty, if we have the best healthcare system in the world and people are getting their money's worth, then we might be willing to pay more for that. So why do costs rise? What drives it? I mean, we do have an aging population. New medical technology. Now you're going to see in some of your videos that we do have some great technology, but so do some other countries, and so you might grapple with why are they able to use that, and why are we charging more for the same technology? Administrative costs are a big deal, and again, something to think through is could we do a better job of less administrative costs, deciding how much, and that was a business that I was in. People submitting medical bills and us running it through software to get the right prices. That all costs money. If we had one set system, would that lower the cost? It probably would. Would that be most effective? I don't know the answer to that. Our medical costs are going up because more people are needing treatment. I mean, chronic disease associated with obesity. I can't emphasize this enough. This is a epidemic of obesity is an epidemic, and anything you can do from a public health standpoint to help people be more healthy and to be a healthy weight is going to help us meet our goal of helping people thrive. It used to be not this way, but malpractice, fears, and defensive medicine. So, a doctor, and again, I was in this field. A doctor may do 2 tests instead of 1 because he's afraid of being sued if he's not super thorough. He may believe that the second test is not necessary, but because his fear of being sued, he may again order more than is necessary. Financial incentives for medical providers, fee for service are things that certainly if someone gets paid for a particular service, they're bound to do more services because they're economically motivated. And let me give you an example. So again, in the business I was in, it was workers' compensation. There were all sorts of unnecessary back surgeries, if you will. And I started in 1990. So in the early 90s, there was something in the workers' comp system called the doctor's presumption of correctness. Basically, what that meant was that if the doctor said it was so, then they could do it. There was no looking at what they were doing by any sort of independent person. So what that resulted in, it was like, for example, and I'm not exaggerating, 500 chiropractic treatments for someone for a back strain. Resulted in back surgeries that most likely were unnecessary. It was probably in the late 90s, they went to more of a utilization review service. So they had a second look at those things and they put those against science. So anyway, what I'm saying is that not every doctor, is not swayed by money and trying to do more services. Now, thankfully, there are controls, at least here in California and other places, to make sure that the patients are getting the best treatment. And then patients demanding the best regardless of the price, right? That's, trying to get, the best drugs or the best, best pharmaceuticals, cost money. It's expensive to research, et cetera. So, if we want the best drugs, there certainly are just economics is going to be more expensive. So how do we reduce medical costs in an aging population? There are proposals to ration care, but they are not what we want to do. And it's preferable to gain control of medical costs overall, right? And so that's where we come in, and also the medical service comes in. So to the extent that we can prevent and postpone chronic illness and reduce other risk factors, which is our job, right? That's what public health people, are tasked to do. That is how we get the cost down of our system, or one of the ways. So a couple ways that we tried to control the costs, and you can read through those here. I'll just mention that I was involved in the managed care field. Uh, there are all sorts of employees that are assigned to just negotiate with providers and set current prices. So that we've tried things. We've also tried DRGs, which do exist a little bit here in California, but have not caught caught on. But what that would be that a doctor takes a patient that has like, for example, a back strain, and he says, beginning to end, with few exceptions, I'm going to charge uh, X amount to get that person to where they don't need treatment anymore. What that number is certainly we would look at, but doctors have fought in that because they're like, well, what about the person that requires like years of medical care, right? I'm not financially, I'm going to get hurt by that. So there's been arguments against that. But again, it would motivate, or it should motivate, I shouldn't say it would, it should motivate doctors to try to give the best treatment and to get people better as fast as they can. So health services research, let's take a look at. So the first area of research that is done in the medical healthcare area is a small area analysis. And what this looks at is that there are large variations in how people treat certain conditions, and sometimes it is supported in that they may not understand. It might be a condition that is not well understood, and so they're just trying different ways to best treat the patients in their area. And sometimes more than one therapy may be appropriate. And let me give you an example of like a condition that's not fully understood, like fibromyalgia, right? People have pain and they're not sure why they have pain. People might treat that in different ways. And I'll give you another example. Certainly, stomach issues, right? Some people treat that with probiotics. Some might treat it with other pharmaceuticals. So each doctor believes that but we can also learn some things like that. Some doctors may change their behavior when they find out that people are having success with doctors, or having success with treatments that they were not performing. So again, this is looking at how people treat the same conditions differently to try to best understand what is the best sort of treatment. So the field of dreams effect. So build it and they will come. Again, if some of you are certainly younger than me, but the movie Field of Dreams. So what they have found is that if you build more back surgery facilities, then more back surgeries are done. If you put in more hospital beds, then there's more hospitalization. And there's also evidence that in some cases that financial considerations may affect medical decisions. We mentioned before, I dealt with several physicians out here in California who did inappropriate back surgeries. Now, why did they do that? They did that because they were financially motivated for the most part. I wouldn't suggest that all of them were inappropriate, but certainly they were motivated by doing more back surgeries. So again, they built more clinics. They had more like outpatient back surgery clinics, and that certainly if they build it, people will come. So outcomes research, when we study different tests and procedures, and we look to see what the outcomes of those are. It really is like observational and epidemiologic study of medical care, right? And I'm going to give you an example, and they give an example here of a prostatectomy when we're looking at prostate cancer, et cetera. But I'm going to give you a specific example that happened to me gosh, a couple years ago, and I'm 57 years old, so I'm in the population that gets, that should get a colonoscopy, fun stuff, right? So I went to my provider a couple years ago, and they said there's an alternative to that. And so my doctor explained to me that a colonos colonoscopy, was no longer needed. And I'm like, well, that's pretty exciting, right? And so what they gave was a less invasive, I'll call it a poop test for risk of being too, crude, but a poop test versus colonoscopy, way less invasive, way less, or way more, or as effective, according to the doctor, in predicting colon cancer as the colonoscopy. So that is good news, and outcomes research was something that benefited me and will benefit people, and will continue to do that. So in 1989, the Agency for Healthcare Research and Quality was set up, really to oversee the different sorts of treatments and their effectiveness. As I mentioned before, and I was right in the middle of this, is when they recommended less back surgery in 1994, there's all sorts of political pressure from back surgeons that almost forced the elimination of this agency. But the agency did recover, and they continue to look at ways to improve medical outcomes and control costs. Medical errors cause between 44,000 and 98,000 deaths per year. And in 1999, the Institute of Medicine took a look at that, and their recommendation was, rather than focus on, not that there's zero focus on the physician that committed the error, the system that committed the error, was they were like, this is a systemic issue, right? So we need to look on improving the system and making things, or creating a system that is less prone to errors than as it currently exists. So medical care report cards, we've said this several times in our class here, but if you can't measure it, you can't manage it, right? And this is so important here. So, managed care plans where all the data is, in one place is probably easier to manage. Report cards, though, will improve incomes, and it's been shown, like in the New York State, measures outcomes in coronary bypass surgery. By measuring these things and looking at areas for improvement, the hospitals are doing better, and they're getting better outcomes, which is the goal in the end. So let's look at one last area, the aging population, right? And we talked a little bit earlier about how the aging population could be driving costs. So what are some things that are driving costs and bad health? One thing is just simply that our American population is getting older, and as people get older, they require more medical care for the most part. Now, how do we push back that sort of that not just growth but poor health? Is what we do is we help in the public health system. We help people get more healthy in their earlier years, right? And really, the challenge in public health is twofold. One is to improve the health of older people by prevention of disease and disability, and we talked about how we do that a little bit earlier. And confront the issues of how costs can be controlled in an equitable way, right? If we're spending money and we're getting great outcomes, that's okay. If we're spending money and not getting great outcomes, that's not okay and not acceptable. So median age has increased from 22.9 in 1900 to 38.2 in 2018. So our population in the U.S. is getting older. Cause of death in the elderly are similar to cause of death in overall population. Obesity, cancer, those sort of things. Percentage of people in good or very good or excellent health are, and these numbers are a little bit surprising, but they were secured by a survey, I'm sure, but 80% of the young, old, 65 to 74 say that they are in good health. 78% of the 75 to 84, and 68% of the oldest of the old, which is 85 and older. I do believe that the older population is healthier than it used to be. That said, there's more of them, right? And so the costs are higher overall to manage that population. So just some trends in the aging population. Females outnumber males in the age group. So after age 80, most women are widowed and live alone. You know, we contemplate what that means for their health, their mental health, and their physical health. Most men are married and living with wives after the age of 80. Men are more likely to die at a younger age. Women are more likely to have chronic disabling conditions. So, as they get older, a bigger part of the healthcare costs likely will come from women who are still alive. So that makes a lot of sense, right? Um, Poverty in these populations, poverty rates are higher for older women than for men. Poverty rates are higher for older blacks and Hispanics. This is a very important question and concept to contemplate and to grapple with, in our pursuit of, making people more healthy and helping them thrive in the end. So that's the idea of compression of mortality. And what is that? It really just says that more people are uh, existing and living up to their biological limit of their lifespan. So more people are living, for example, now up to the expected life expectancy than had in the past. And what's compression of morbidity? It's basically that people will thrive longer in their lives, so they will have uh, less morbidity, less disease, and that will impact a shorter period of their life than it had before. So, how do we do that is really a key uh, driver for us in the public health is how do we help people? Again, I love the word thrive because it initiates the idea that people are not just doing okay, not just living, but are doing really well and feeling well and thriving in their lives. So factors that affect health and old age, I mean, these are not a whole lot different than impacted other ages, but smoking, those that stay active. I have a almost 90-year-old mother who still cuts her own grass, still does a lot of things. So I think that staying active really helps. And then just having medical care, right? Having access to medical care, so when there are issues, they can address those. So we've looked at, really that the idea of a person's health outcomes as they get older are, certainly influenced by what they do when they're younger and middle aged. But we've gotten to old age now. So what are some of the things that we can do to help manage disease and disability? I mean, immunizations against pneumonia and influenza are clearly important things. Medications, sometimes I would suggest that we over medicate our populations. So, certainly the less medications at this point that you have to take, the more you're going to thrive. Osteoporosis is an important thing to manage as they get older, and then also falls impact many older people, and can push them into a state of disability that is tough to get out of. Other things, impairment of vision and hearing. Uh, certainly these are things that we need to maintain as we get older. And, as a community, as an organization, we need to make sure that these are things that are also taken care of in our older, vulnerable population. Alzheimer's and other dementias. Uh, these are things that, uh, again, you may not have been impacted by this, but those of us that are older, certainly have been impacted by this. And risk increases with increasing age. Tremendous burden on the caregivers. If you've ever had to uh, be around or care for someone that is, uh, can't remember what they did a couple minutes ago, it's a very challenging and expensive endeavor. Um, there's a lot of research going on to find out how we might, and a lot of it points to earlier in life, the things we do earlier in life. For example, if we exercise, if we challenge our minds. All of these things can help keeping dementia and Alzheimer's from expressing itself. Um, so again, our role in public health is to catch those people before they get here and tell them the importance of the preventative benefits of what their lifestyles and what they eat and what they do, how much they sleep, how much they challenge their brain. No cure exists. I have a good friend who is currently working on a medication for Alzheimer's that is suggested to delay its progression. Pretty exciting stuff if, in fact, it works. But again, the best thing is going to be primary prevention earlier. And the thing that's a challenge with Alzheimer's is that most of the research says that it really starts to develop in someone's like 40s and 50s, right? So you don't know about it, and you could manage at that point, but they're not seeing signs of it yet, so most don't address it. So we've looked at this slide before, and again, back to our role in public health. Here at the bottom point here, integration of public health and medical service to reduce demand for medical care. Prevents and postpones chronic illness and reduces risk factors. This really is what we are doing in the public health arena to try to help people thrive. So real briefly, and this is the last little thing that we'll look at, let's look at the achievements of public health in the 21st century. The use of routine vaccinations. We've not that we've conquered infectious disease, but we're better at managing that. Improvements in motor vehicle safety. I mean, seat belts, airbags, all of these things has greatly reduced the disability and what have you just from driving a vehicle. Safer workplaces. Again, this was my space, workers' compensation. Certainly machinery, et cetera, all is safer than it was even 50 years ago. Control of infectious diseases, decline in deaths from heart disease and stroke, safer and healthier foods. Now, I would put a caveat here. We also have foods that are not good for us. And again, not as a result necessarily of people doing bad stuff, but in our striving to create more food that had a longer shelf life, we may have in fact created foods that over time kill us. Healthier mothers and babies, access to family planning, fluoridation of our drinking water, and recognition of that tobacco use is not good for us at all. Now, this is the perfect slide to end on because what I'm putting in front of you here are some of the challenges that you will face, regardless of whether you're in public health or in the medical field or what have you. Renewed threats from infectious diseases. We are more of a global population, right? We move around more, we're more exposed to different threats. So certainly that's something that we need to look at and figure out how we can lessen the threats from infectious disease and how we treat those diseases once they rear their ugly heads. I think this is very important here, understanding and altering human behavior. As we've seen in the different studies, I mean, it is, and this is emphasized in that book that I shared with you, Change or Die, right? There are so many of the population that you can give them facts, you can give them strong science, and yet still they don't change. So we need to figure out why that's the case. And again, we gave you some techniques like motivational interviewing, the human belief model, some of those that might help you help other people alter their behavior for the better. The rising cost of medical care, this seems to be a United States issue, not predominantly, but we're the most expensive healthcare. So how do we deal with that? And how do we deal with it in an ethical way where we're not spending less equates to less services, but yet spending less and just being more frugal about the use of the services and still getting great results. We need to strengthen the public health system. that there's not a lot of resources often that are put into public health. It's more into fixing people than keeping them from getting sick in the first place. So certainly we need to look at ways to lobby for uh, more resources for the public health system. We need to continue to look at disparities in health, persistent disparities in health. The built environments we've talked about, uh, the social environments, the different climates in which people exist that impact their health. So that certainly is a very important piece for anybody that's involved in public health, is to why are there still to varying degrees the haves and the have-nots. And then the last here, and I listed it last just because there's much debate about this, but climate change. Certainly we've seen periods of like drought, for example, in the past. Out here in California, we're currently going through a pretty bad drought. So whether that's driven by climate change or not is debatable, but it's certainly something we want to research because having higher heat and or cold and or not having enough water or whatever that might cause is worth looking into, right? Whether we believe that it's driven by human behavior or not, we need to research what's causing that. So thank you so much for going through this journey with me in learning more about public health. Again, go out there in whatever ministry or whatever discipline that you're in, look to make people's lives better and help make them thrive.